Welcome to your most favorite channel, Heartbeat. My name is Dr. Amrit Kejriwal. As a student, I say most of the teaching will be digitalized. Hard copies of books will become obsolete. They will be replaced by soft copies. Lectures and lecture halls will cease to exist. They will be substituted by videos and online classes. Practical classes will remain in medical sciences. We have to prepare ourselves for a revolution in learning and teaching methods in all disciplines. Today we learn something about respiratory acidosis. Channel's name is Heartbeat. My name is Dr. Amrit Kejriwal. Mechanism. This presence of increased CO2 in the inspired air. This is one mechanism of respiratory acidosis. Another mechanism is alveolar hypoventilation. Third is increased CO2 production by the body. Overproduction is matched by increase in ventilation. Coming to the pathology, it can be seen in severe pulmonary disease, respiratory muscle fatigue, abnormalities in ventilatory control, or failure of buffering mechanisms. All these three cause failure of the buffering mechanisms. Etiology. There can be central causes such as drugs, anesthetics, morphine, sedatives. There can be stroke or infection, airways disease such as obstruction or asthma. There can be parenchymal disease of the lung such as emphysema, pneumoconiosis, bronchitis, adult respiratory distress syndrome, barotrauma. There can be neuromuscular problems such as poliomyelitis, kyphoscoliosis, myasthenia gravis or muscular dystrophies. There can be miscellaneous causes also such as obesity, hypoventilation and permissive hypercapnia. Respiratory acidosis, overproduction of CO2 leads to increased alveolar ventilation, and alveolar hypoventilation increases the PaCO2. Increase in PaCO2 alters the Henderson-Hasselbalch equation. So, there is a decrease in pH. So, if this component increases, this has to decrease, and because of this, the bicarb also increases. So, the PCO2 increases, bicarb increases correspondingly, and serum bicarb usually does not increase above 38 millimoles per liter. pH may still be normal in coexisting acid-base disorders. If PaCO2 is increased, check bicarb. In acute cases, bicarb should increase by 0.1 millimoles per liter per millimeter increase of PCO2. And in chronic cases, bicarb should increase by 0.4 millimoles per liter per millimeter increase of PCO2. If not, another disorder exists. In acute, PCO2 is greater than 45 with acidemia of pH greater than less than 7.35. In chronic, PCO2 is still greater than 45 with normal or near normal pH elevated. Bicarb is greater than 30 millimeters of mercury and associated with renal compensation. Compensation in acute acidosis is completed within 5 to 10 minutes of onset of hypercapnia. Occurs due to involvement of non-bicarbonate buffers, and plasma bicarb levels change by approximately 0.1 milliequivalent for every acute increase in PaCO2 by 1 millimeter of mercury. Compensation in chronic acidosis requires 3 to 5 days of persistent hypercapnia, a transient net increase in urinary net H plus excretion, a persistent increase in the rate of renal bicarbonate reabsorption, and plasma bicarbonate levels increase by approximately 0.3 milliequivalent for every chronic increase in PaCO2 by 1 millimeter of mercury. Clinical feature. The clinical features depend upon the duration of respiratory acidosis, severity of respiratory acidosis, and plus minus hypoxemia, and also the presence of coexisting disorders. Acute increase in PaCO2 can cause anxiety, dyspnea, confusion, psychosis, hallucinations, and coma. Whereas chronic increase in PaCO2 can cause sleep disturbances, loss of memory, daytime somnolence, personality changes, impairment of coordination, motor disturbances, tremor, myoclonic jerks, and ataraxics. It can also cause headaches, papilledema, abnormal reflexes, and focal muscle weakness. Initially, it may cause increase in the cardiac contractility, later on it causes decrease, and initially it causes systemic vasodilation, later on it causes vasoconstriction. And effect of respiratory acidosis causes renal, on the renal system causes salt and water retention. Approach: as usual, we have to take the detailed history, do a detailed physical examination, and do the investigations. For the non-pulmonary causes, you have to take a detailed drug history, measurement of hematocrit, and assessment of upper airway, chest wall, pleura, and neuromuscular function. For the pulmonary causes, we need the pulmonary function tests such as the spirometry, diffusion capacity for carbon monoxide, lung volumes. We need the arterial PaCO2 levels and oxygen saturation. Arterial blood gases, it will always show increase in PaCO2. Acute pH is low and bicarb is near high normal. And in chronic acidosis, pH is normal to low and bicarb is high. Treatment depends upon the severity, rate of progression, may require intubation and mechanical ventilation. Oxygen is to be administered very carefully, and PaCO2 should be lowered gradually in chronic respiratory acidosis. And potassium and chloride supplementation may be required. Primarily treatment is directed at the underlying disorder and avoid rapid correction of chronic hypercapnia. Pharmacological therapies. So, we can use bronchodilators such as beta agonists or anticholinergics. You can use drug antagonists, naloxone used in narcotic overdose and flumazenil used in benzodiazepine poisoning. Here are the other pharmacological therapies: respiratory stimulants such as medroxyprogesterone or acetazolamide and theophylline. You can use also oxygen therapy and ventilatory support.